Our first segment is 10 questions on airway management. Don't forget, if you have an answer, go ahead and just put it in the chat. 56-year-old man has labored shallow breathing at a rate of 28 breaths a minute. He's responsive to pain only. You should A, suction his mouth for 15 seconds and insert an OPA. B, ventilate him with a BVM device at a rate of 30 breaths per minute. C, place him on his side and administer oxygen via non-rebreather mask. Or D, insert an NPA and begin assisting his ventilations. How are we going to treat this guy? He's 56 years old. When it says he's responsive to pain only, all that means is the guy's unresponsive, almost unresponsive, right? So he's kind of like knocked out, but you do a sternal rub on him and he kind of opens his eyes. Not good, right? You can talk to this guy all day, he ain't going to answer you. But he's got some shallow breathing at a rate of 28 breaths per minute. All right, let's check out this answer. D. So the reason why it wasn't A, B, or C, there's no indication for suction. Please don't choose suctioning during your exams if there's no indication for it, okay? It doesn't say anything about gurgling noises. It doesn't say anything, right? And also an OPA would be kind of, why am I putting an OPA on this guy? This guy's responsive to pain. The likelihood of this guy having a gag reflex is pretty damn high. Ventilate him with a bag of 30 breaths per minute. That's incorrect, right? We don't breathe it for anybody at 30 breaths per minute. Place him on his side, administer O2. That is not really indicated. But these two are the best answers that were on here. D is just a better answer. Patient in this scenario is not breathing adequately. He's responsive to pain only. His respirations are rapid, labored, and shallow. You should insert an NPA, which usually is tolerated by patients who are semi-conscious and have a gag reflex. Assist his ventilations with a BVM. When assisting a patient's breathing, you should squeeze the bag to ensure that he or she receives 10 to 12 breaths per minute. Okay. Now, real quick on utilizing a BVM. Do not utilize a BVM just because somebody has a breathing rate that is not what you like to see, right? 28 breaths per minute is not that big of a deal. I'm going to be honest with you. It's not. Anybody with mild anxiety is probably breathing at 28 breaths per minute. We're not worried about that. Now, the fact that he's breathing labored and shallow, those are bigger issues, right? Labored and shallow is now a problem. And the fact that my patient is only responding to pain worries me as a provider, okay? If they were just, if all this said was a 56-year-old man, his breathing rate is 28 breaths per minute, is responsive to pain, guess what? C would probably be a better answer, okay? But the fact that it said labored and shallow breathing, that is the only reason why I'm going to assist ventilations. That's it. That's kind of how this game is played. You need to be able to decipher why a question is asking you or what the question is technically asking, right? All right, next one. Tidal volume of an unresponsive patient is rapidly assessed by what? A, auscultating his or her lung sounds. B, evaluating for the presence of cyanosis. C, observing for chest rise during inhalation. Or D, counting the patient's respiratory rate. Tidal volume, unresponsive patient, auscultate his or her lung sounds, evaluate for the presence of cyanosis, observing for chest rise, or counting the patient's respiratory rate. Let's check it, okay? Tidal volume. Tidal volume. So the tidal volume is the amount of air that can go into your lungs, right? It's a measure of the depth of breathing and the amount of air in mLs, all right, that is move in or out of our lungs during a single breath. Average tidal volume for an adult male is approximately 500 mLs, approximately, okay? people range from like 4 to 600. The quickest and most effective way to assess a patient's tidal volume is to observe his or her chest rise. If the chest rises adequately during inhalation, tidal volume is probably adequate. If the chest rises very little, as in shallow breathing, tidal volume is reduced. Auscultating breath sounds can give you an idea of the patient's tidal volume. All right. When we say that there's 2 good answers, 1, 2. All right. Bilaterally diminished breath sounds may indicate reduced tidal volume, but it's quicker and easier to observe for chest rise. The other 2, cyanosis and respiratory rate, have 0 to do with tidal volume, the amount of air that's going into somebody's lungs. Easier question, right? Real quick, just on the whole tidal volume topic, be mindful how much air is being delivered to patients, okay? If we're ever utilizing something like a BVM, those BVMs they can have up to 1,600 mLs in those BVMs. Be mindful on where you're placing your hands on those bags, and pay attention to how forcefully you're squeezing those bags, because there's no reason to give more than what the patient's tidal volume is. Question to you guys is what happens if I give more tidal volume than what the patient is able to take? For example, if my lungs are 500 mLs and I use a BVM that has 1,600 and I squeeze the bag at full capacity, all right, Kiara called out gastric distension. Absolutely. Okay. So understand, those of you who do utilize the BVMs, I'm not saying BVMs are a bad choice or a bad device, but understand that if you use a BVM, the likelihood of you getting air into the stomach is high, really high. For that matter, be careful on how you're bagging these patients. If you can use a supraglottic device for you EMTs, for like a king tube, that's what's going to reduce the amount of air that's going into the stomach. Okay. Is it foolproof? Absolutely not. But is it better than just bagging somebody over a long period of time? Yeah, it is. Okay. You're going to have a lot of issues if you just continue to bag somebody without using a device. Ace says that you can overinflate the lungs. Absolutely. You can actually cause barotrauma as well. Barotrauma is just like rupturing the lungs. You can cause a pneumothorax, things of that sort. So understand that you just using a BVM is dangerous. And just because of the times, I kind of want to bring up some things regarding COVID-19 and treating our patients. On the tip of your BVM, there's an exhaust port. Every single time I bag somebody, there has to be a way that air gets exhausted from the BVM. With that being said, if you do not have any sort of HEPA filter or filter on your BVM, you are going to spray whatever is in that patient's mouth all over the truck, small particles, right? With that being said, utilizing a BVM is a very easy means of spreading things like COVID, which is pretty scary. All right. Number 3, which of the following clinical findings is most consistent with chronic respiratory disease? Which of the following clinical findings is most consistent with chronic respiratory disease? A, irregular pulse. B, barrel-shaped chest. C, altered mental status. Or D, use of accessory muscles. This one is this one's kind of difficult because there's 2 really good answers on here. Reread it. Give you guys some time to answer this. Which of the following clinical findings is most consistent with a chronic respiratory disease? I'm just going to say the two good answers: barrel-shaped chest or the use of accessory muscles. And that's how you're going to have to answer these questions. All right. You're going to have two answers that are crap. Let's be honest. Chronic respiratory disease. Respiratory disease. I'm going to go with it. Oof. We knew that those are two of the good answers. Now let's see what our feedback is. So in certain lung diseases, such as emphysema and asthma, I'm already going to tell you that I know that there's air trapping. So, and I'll explain that. Air is gradually and continuously trapped in the lungs in increased amounts. This increases the anterior posterior front of the back and causes what's known as air trapping, causing the chest to assume a barrel shape. Barrel-shaped chest indicates chronic respiratory disease. Okay, accessory muscle use and altered mental status in a patient in respiratory distress should be assumed to be an acute finding. Irregular pulse could be the result of a primary cardiac problem. So they're just saying that accessory muscle use is seen in patients with respiratory distress. So they're not saying that it's technically related. Well, it could be related because these patients always are in respiratory or distress. That's the reason why it kind of threw me off. I was like, oh my God, those two are great answers. Just because barrel-shaped chest, once you read why that's the answer they chose, that is the only thing that is associated specifically with chronic respiratory disease. Now, these patients that have COPD, remember, chronic obstructive pulmonary disease, these patients have emphysema or they have chronic bronchitis. Patients that have emphysema and believe it or not, asthma, bad asthmatics, what happens is the bronchioles, they start to really constrict, hence why we have to give them bronchodilators, right? But their bronchioles really constrict, and air that passes through the alveoli to go for diffusion, a lot of that air starts to get trapped in the alveoli, and the alveoli start to expand. Okay, these patients don't have an issue getting air to the alveoli, they have an issue getting the air out. So what happens is there's overexpansion. And over time, believe it or not, the more forceful that this patient breathes, because they're having shortness of breath, the more that they push and they actually purse their lips and everything, and they do the tripod position, kind of like what this guy's doing right now. They put the two arms down and they kind of pick themselves up, and they really forcefully breathing. The harder that these patients breathe, the more air that gets trapped. Okay, patients that have chronic COPD or that have bad asthma and they deal with it for long periods of time, they actually start having a barrel-shaped chest. The method by which you administer O2 to a hypoxemic patient depends mostly on the A, presence of absence of cyanosis, patient's level of consciousness and heart rate, C, suspected underlying cause of hypoxemia, or D, the severity of hypoxemia and adequacy of their breathing. So it's the method by which you administer oxygen. How are we determining who gets oxygen? Okay, everyone's kind of on the same page with this one. So D was definitely the best answer. When we start looking at this, it's like, okay, why am I going to give somebody oxygen? If you note cyanosis ever, understand that cyanosis is a late sign of hypoxemia. Okay, this patient's been hypoxic for a little bit. Just because your patient's not cyanotic does not mean that we can't give them oxygen. We don't want to see cyanosis. Patient's level of consciousness and heart rate would never really determine if I'm giving a patient oxygen or not. Suspected underlying cause of hypoxemia, kind of a decent answer, because you're like, okay, if this patient has something that's causing hypoxia, then I should be giving them oxygen. So I could see how that answer is going to screw people up. They're going to see that one, and they're going to be like, yeah, I would give somebody oxygen if I have an underlying reason to give it. I get that. But severity of hypoxemia and the adequacy of breathing was definitely the best answer. Now, let's talk about administering oxygen and how this works with adequacy of breathing. if my patient is able to breathe on their own, which this is most patients that we encounter that have an adequate breathing rate. When I say adequacy of breathing, you guys know what normal breathing looks like. You see that they have a normal tidal volume. Adequate breathing, their breathing isn't shallow, it's not labored. These patients do not need to be put on a non-rebreather mask. Just because I tell you that your patient is breathing at 30 times per minute and you're like, well, shoot, 12 to 20 is normal. This patient needs to be put on a non-rebreather. No, not necessarily, okay? Just like, again, if somebody has breathing rate of 30 breaths per minute and they're anxious, okay, let's say they have chest pain, something of that sort, does not mean that you need to throw them on a non-rebreather mask if they're still breathing adequately, okay? If they're like I said, their tidal volume is normal. If they're struggling to breathe and their breathing is now labored, and at 30, that's a completely different ball game. Okay, then I could jump to the mask. But most patients that we have, we jump to a nasal cannula first. Okay, especially if I can tell that their breathing is adequate. And it's funny because a lot of the calls that I do run, I get there and it's a shortness of breath call, and I show up and I'm like, "Hey, what's going on? You know, my name's Mike. Why'd you call 911?" And they're like, "Oh my gosh, I'm really struggling to breathe. I've been having shortness of breath now for about 30 minutes. Let's be honest. If someone's talking to me like that, are they really having shortness of breath? That's the kind of stuff that you, as an EMT or as a healthcare provider, you're going to have to be able to tell. Some things that the patients are going to tell you are going to be very beneficial. Remember that you don't know how these people are feeling. They know their body better than you do, but I can visually see if someone is breathing adequately. I can tell what kind of oxygen I'm going to use just based on my assessment, not based on what my patient's saying. Not always, all right? Tidal volume is defined as volume of air inhaled or exhaled per breath. This is BS, man. How are we getting to these questions? Volume of air that remains in the upper airway. Total volume of air that the lungs are capable of holding. Whoa. Or D, volume of air moved in and out of the lungs at each minute. There are two answers here that are great answers, man. God, I hate that. Let's do this. All right. Okay, so remember, we're talking about tidal volume. We just spoke about tidal volume. What is tidal volume? Tidal volume. And both of them aren't wrong, okay? But remember what the definition is, okay? The definition of tidal volume, the amount of air that is inhaled or exhaled per breath. Total volume of air in the lungs that lungs are capable of holding. Yeah, that the amount of air that's allowed inside of each lung is, I'm not saying that it's not the tidal volume, but understand that each breath that I take, there is residual air that remains in your lung. Okay. So for example, let's say that my lungs can withstand a total volume of 800 mLs of air. Every single time I breathe in and breathe out, I'm not breathing in and out 800 mLs of air. Neither are you. Nobody is. Okay, there's residual air in your lungs at all times. The tidal volume is the amount of air that is inhaled and exhaled, the total amount per breath. Okay, that's why these two answers are great, because you're like, oh my gosh, the amount of air that my lungs have should be the tidal volume, the amount of air that can go in. That's the easiest way to basically kind of explain what tidal volume is to somebody. It's like, yeah, dude, it's the amount of air, the total amount of air that you're going to give to that patient, or the amount of patient that patient has. Technically, you know, and just like we see in this question, kind of not the right way to explain it. It's just the total amount of air that is breathed in and out per breath. We already talked about how tidal volume is assessed. Now, the reason why D was not the right answer, anybody want to take a guess at what this definition is called? Volume of air moved in and out of the lungs each minute.
Volume.
Yep. Good, Monica. That's the minute volume. All right. Minute volume. Two completely different definitions. So you just got to know your definitions for that one. All right. Then next question. Which position should you place an uninjured, unresponsive patient with a respiratory rate of 14 breaths per minute and adequate tidal volume? Are you going to place them supine, full Fowler's position, semi-Fowler's position, or lateral recumbent? I'm going to reread the question. What position should you place an uninjured, unresponsive patient with a respiratory rate of 14, okay, and adequate tidal volume? I got two good questions. I got two decent answers here. I see some answer changing. All right, let's answer this one. There was a lot of you that answered semi-Fowler's. Not bad, okay? And those are the two, like, decent answers. Full Fowler's, completely ridiculous, right? I'm not going to place somebody in full Fowler's unless I have to. Typically, my patients that are in full Fowler's are having respiratory distress, and they are conscious. Supine, I usually don't put anybody in supine position unless I am ventilating for them. We're doing some sort of procedure that requires supine. The big one here was this, right? Unresponsive. You need to know when you're going to place your patient in semi-Fowler's, or are we placing our patient in lateral recumbent? Now, the thing about this patient is they are cool, right? We got uninjured. We got a good respiratory rate with adequate tidal volume. This patient has zero issues. What is their only complaint? They're unresponsive. You want to know what these patients are? For us, these are drunks. Okay, these are our typical drunk people that we pick up. They're hammered, and we lay them on their sides to reduce the chance of what? Aspiration. Okay, so it's called the recovery position. And aspiration, I just don't want them to breathe in their own vomit if it occurs, right? Recovery position, which involves placing a patient on his or her side, is known as lateral recumbent. Used to maintain a patent airway in unresponsive patients who are not injured and who are breathing on their own. Patients who are in shock or require positive pressure ventilation should be placed supine, because now you got to perform a procedure. Semi-Fowler's position involves placing a patient in a semi-sitting position at 45 degrees. This is the most comfortable position for most patients. Full Fowler's position involves sitting a patient upright at 90 degrees, often used for patients in respiratory distress. Now, somebody just wrote, oh yeah, we got to put them in left lateral. Understand, on our patients who are this patient right here, I don't care what side you put them on, left or right. What's the whole reason why we do left lateral recumbent? Usually we do left lateral on pregnant females, okay? And the whole reason behind that is to reduce the pressure of that uterus off of the inferior vena cava. We don't want to try to lower blood pressure, things of that sort. The whole reason why we're placing this patient on their side in this scenario, they didn't really give us much information on this patient, but it's just because they're unresponsive, okay? Like I said, we don't want to allow them to aspirate if they do vomit. Next question. 35-year-old patient complains of shortness of breath. He's conscious and alert and able to speak in complete sentences, although there is slight difficulty. Assessment reveals diffuse wheezing on auscultation. Respiratory rate of 24, heart rate of 110, oxygen sat of 96. Which of the following interventions would most benefit this patient? A, beta agonist. B, assisted ventilations. C, supplemental O2. Or D, inhaled bronchodilator. Oh, I'm sorry. A said beta antagonist. That's huge. Okay. A, beta antagonist. B, assisted ventilations. C, supplemental O2. Or D, inhaled bronchodilator. This is our patient who's able to speak in complete sentences, slight difficulty. You have diffuse wheezing with a respiratory rate of 24. You got to be able to see what the question's asking. How are we going to treat this patient? Or what can this patient benefit most from? All right, let's talk about this answer. And let's talk about how I'm looking at this question. Okay, the question starts off with shortness of breath, right? I know my patient's having trouble breathing. So how I'm reading this question, because guess what? This question is relatively long compared to a lot of the other questions we see. Conscious, alert, able to speak in complete sentences. Okay, so that's pretty good. That's good thing to see. But they said there is some slight difficulty, so I'll highlight that. That's kind of important. This is big, very big. Respiratory rate of 24. Okay, and my O2 sat of 98 or 96. Those are really the only thing that I care about in that question. I'm going to be honest with you. I don't care about the heart rate. I mean, conscious and alert is kind of important, but the fact that they're speaking in complete sentences, obviously they're conscious. So by just that, I'm already saying, okay, if I took this out of this question right here, diffuse wheezing, if I put a strike through that, and let's just say that this patient did not have diffuse wheezing. What if that diffuse wheezing was clear? Assessment reveals clear lung sounds on auscultation. Guess what? Those of you who answered C would have been right. The fact that this patient had diffuse wheezing changed everything in this question. Okay? And guess what they require? A beta agonist, not a beta antagonist. Okay? The second I saw that it said beta, I was like, oh my gosh, there's the answer right there. But then I saw antagonist, I was like, oh crap, they changed it up. An inhaled bronchodilator is a beta agonist. Patient's clinical presentation is a classic bronchospasm, hence the diffuse wheezing, right? Primary treatment for wheezing is inhaled bronchodilator, beta agonist, which will dilate the bronchioles and make them easier to breathe. Additional bronchodilator treatment may be needed if his or her symptoms do not improve. Oxygen is not indicated for patients because his or her oxygen saturation is greater than 94%. Whoa. All right. He is not in need of assisted ventilations because there's no outward signs of inadequate breathing. If I gave somebody an antagonist, it would stop any type of beta from occurring in that location. For example, our beta agonist causes bronchodilation. If I did a beta antagonist, it would not allow for any dilation to occur. But this is kind of how I would break this question down to determine what is the best way to treat the patient. Next question. Snoring respirations in an unresponsive patient are most often the result of what? A, foreign body airway obstruction. B, upper airway obstruction by the tongue. C, collapse of the trachea during breathing. Or is it D, swelling of the upper airway? Snoring respirations in an unresponsive patient are most often resulting of what? Good. You guys are doing good on this one. Snoring respirations. All right. And it's just most often, right? Because that, even though it is highlighted or it's in capital letters, is kind of the most important part of this question. Because guess what? Snoring respirations, it's funny that when I was reading this question and I saw snoring respirations in an unresponsive patient, I was like, yeah, that could be caused by a foreign body airway obstruction, of course. Guess what? It could also be your tongue is considered a foreign body airway obstruction. Well, not necessarily because it is part of your body. But the upper airway obstruction by the tongue is the most common cause of snoring. Okay. Now, whenever we do come across these patients that are snoring and they have a reduced respiratory rate, okay, due to the snoring, they could have inadequate tidal volume due to the snoring. We assist them by opening the airway, right? Head tilt, chin lift. If the patient has outward signs of trauma, we can go ahead and do a jaw thrust maneuver. But understand that you don't just leave these patients and let them snore, especially if they have low O2 saturations, things of that sort. Typically, we see a lot of these patients and our overdose patients, right? We have a patient that's overdosed on opioids. We show up, you hear the snoring when you walk in, or the patient's not breathing at all because they're so weak that their tongue blocking their trachea just kind of like doesn't allow them to breathe. Do a head tilt chin lift. We want to try to always get that tongue away from our patient's trachea to allow them to inhale. All right. But yes, that was the best answer. Signs of inadequate breathing in an unresponsive patient includes inadequate breathing in an unresponsive patient. A, irregular pulse. B, warm, moist skin. C, symmetrical chest rise. Or D, cyanotic oral mucosa. Signs of inadequate breathing in an unresponsive patient. This is a weird question. The question's not that weird. The answers are weird. Inadequate breathing in an unresponsive patient. Would you have an irregular pulse, warm, moist skin, symmetrical chest rise, or cyanotic oral mucosa? All right, we got some answers on here. Let's take a look at what we got. The only reason why I chose D is because A, B, and C have nothing to do with inadequate breathing. I don't give a crap that this patient's unresponsive in this question. I'm just looking for signs of inadequate breathing. That's all I care about when I read this question. I was like, does an irregular pulse have anything to do with inadequate breathing? Okay. Unless the patient threw a clot and has PE or an embolism, like maybe, but no, an irregular pulse has nothing to do right now with our irregular breathing. Warm, moist skin, nothing to do with it. Symmetrical chest rise, we all have symmetrical chest rise. At least I hope you do. Yeah, I don't think you're having inadequate breathing. I know I'm not. Cyanotic oral mucosa is the only thing that was like, that's not good. Cyanosis is bad. Signs of inadequate breathing in both responsive and unresponsive patients include a respiratory rate that's too slow or too fast, shallow, reduced tidal volume, irregular or gasping respirations, asymmetrical or unequal chest rise, any abnormal respiratory sounds, or abnormal skin color conditions. And cyanosis is one of them. An irregular pulse indicates a cardiac dysrhythmia. Not really means anything for inadequate breathing. But they're saying that the answer is B and C. If either of those are, you know, not normal. For example, cold skin. If it said something like cold and moist skin, that could have been an answer. Or asymmetrical chest rise could have been an answer. But cyanosis was the only good one on this one. Last question for respiratory. Which of the following processes occurs during inhalation? All right, during inhalation. The intercostal muscles of the diaphragm both contract. The intercostal muscles relax and the diaphragm descends. The diaphragm contracts and the intercostal muscles relax. Or is it D, the diaphragm descends and the intercostal muscles relax? I just read C and D at the same. The diaphragm contracts, intercostal muscles relax. That's C. And then D, the diaphragm descends and the intercostal muscles relax. So this is during inhalation. What is happening between intercostal muscles and your diaphragm? Do they both contract at the same time? The intercostal muscles relax and the diaphragm descends? Or does the diaphragm contract and the intercostal muscles relax? Let's pick one. All right. They're both contracting. During the active process of inhalation, the diaphragm contracts, causing it to descend. That's the only thing that was like throwing me off in this question, was the use of the word descend and contract. For answer B, it says that the diaphragm muscle descends, and then over in C, they said the diaphragm muscle contracts. So that's the one thing that was throwing me off with this question, because I'm like, okay, if you're inhaling, this is how I look at it. Whenever I inhale, my lungs need to fill with air. To fill with air, my diaphragm needs to get the hell out of the way. Okay? It needs to descend. It needs to move. Now, understand, whenever your diaphragm contracts, it gets the hell out of the way. It goes down, it descends. When your diaphragm relaxes, it goes back up into position and assists with your exhalation, kind of like pushing the air out of your lungs, right? This increases vertical dimensions of your chest, like I said, to allow those lungs to expand. At the same time, the intercostal muscles between the ribs contract, increasing the horizontal dimensions of the chest. These two processes cause intrathoracic pressure to fall and air to rush into your lungs. Okay. When I thought of this, I was like, okay, when my patient's taking a deep breath and they're having shortness of breath, you can see retractions, right? And remember, retractions is just, it's the intercostal muscles contracting. You can see the muscle, accessory muscle use that's occurring in your intercostal space. All right, so looking at this, here's our intercostal spaces, right? And we can kind of see in between the rib cages during inhalation. That's intercostal muscle use, right? Or also known as retractions. So understand that that's kind of what we're talking about during inhalation. Those muscles do contract. All right. So that's why we didn't pick C or D, because it says relax.